Hello, and welcome to the Diagnosis-Specific Education Session, X-linked Agammaglobulinemia, or known as XLA. My name is McKenna Kresley, and I am a communications specialist here at IDF, and I will be the moderator for this session. Before we begin, please remember that each individual's treatment and condition is unique. The information presented during this session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of a physician or other qualified health provider with questions concerning a medical condition. Questions about this topic will be answered at the end of the presenter's talk. Please submit your questions to me, McKenna Kresley, via the chat box. The presenter will answer as many questions as possible during the session's time. At this time, I would like to welcome and introduce our presenters, Dr. Vivian Hernandez-Trujillo and Dr. Maite de la Morena. Dr. Hernandez-Trujillo is the Director of the Division of Allergy and Immunology at Miami Children's Hospital, Nicholas Children's Hospital, an Associate Clinical Professor at the Herbert Wortham School of Medicine at Florida International University, and works at Allergy and Immunology Care Center of South Florida. Dr. De la Morena is a professor of pediatrics and the clinical medical director for the Division of Immunology at Seattle Children's Hospital and the University of Washington. She leads a partnership with the Department of State Health to provide follow-up for all infants identified by the Skin Newborn Screening Program for the state of Washington, and is an integral part of the non-malignant transplant program at Seattle Children's Hospital in collaboration with the faculty at the Seattle Cancer Care Alliance and the Fred Hutch Cancer Center. And with that, I'm gonna let Dr. De la Morena take it away.
Thank you, McKenna, for your kind introduction. My name is Maite de la Morena, and I'm really delighted to be here today, along with my dear friend, Dr. Vivian Hernandez-Trujillo, to give you an update on XLA. And these are our conflict of interests outlined here. And so today we, Dr. Hernandez and myself, we're going to tag team a little bit, and we have a very ambitious agenda, which is defined here. We're going to talk about the definitions of XLA. We'll talk about clinical features and show you some novel unpublished data to share with you. We'll talk about diagnosis, inheritance, current therapies, what to expect with XLA, and exciting new opportunities and what's next for this condition. So I like to put things in a little bit of a perspective, and many of you are very familiar with XLA, but those of you who have never heard the term or are new to the IDF, I just wanted to give you an update of who this person was. And this is Colonel Ogden Bruton. And he was a pediatrician at the Walter Reed in the mid-50s. And at around that time, in the middle of the last century, is when gamma globulins were being discovered. And so when things get discovered, new instruments come up. And new instruments that were looking at proteins in the blood had just arrived at the Walter Reed. And so what you can see in this slide is the readout of that instrument. And that instrument was a Theselius instrument that read protein electrophoresis. And in other words, it looked at all the proteins in the blood. And what you can see is a peak here, which is your albumin and the different fractions. And then here, the second to last is a gamma fraction, and that's where the gamma globulins are. And so it just so happened that the serum of a child who was admitted at the time at the Walter Reed, who had been admitted 19 times for strep pneumonia, the serum got into this new machine. And what you can see in the second part is that this gamma fraction here, the gamma part here is 0. And that's, can you see my, I don't know if you can see my pointer, but this is the gamma fraction. There's nothing there. It's flat and not like a little bump here. And you can see that there's no gamma globulins. And then the child was given gamma globulin, and sure enough, now you have a little bit more proteins. So this is the first time that there was a connection between the fact that you needed gamma globulin to get rid of certain types of bacteria. And so the disease at the time was called Bruton's Agammaglobulinemia because of Colonel Bruton. So fast forward 30 years, and in that period of time, we've learned that the disease that we call now XLA represents an arrest in the development of B cells. And what that means is that B cells are born in the bone marrow, where they undergo a series of biochemical events that allow them to express on the surface of the cells the antibody molecules. And so these B cells go from being different stages to being a mature B cell. And then the last one on the right is called a plasma cell that releases these squiggly cartoons, which are your antibodies. And what we know is that the arrest in development of B cells is occurring at this very early stage in the bone marrow. And so patients with XLA have subsequently no B cells in circulation, and therefore no antibodies. So the disease is called X-linked agammaglobulinemia, agamma meaning no antibodies, and X-linked, which means that the disease affects males and the females are carriers. And Dr. Hernandez will talk about the inheritance pattern. So between the time 1952 that Dr. Bruton described the first child with XLA and the discovery of the gene called Bruton's tyrosine kinase, BTK, B for Bruton's, and tyrosine kinase is an important enzyme that help the biochemical events that are occurring within the cells to occur. This is the gene that is missing or not functional in patients with BTK. And so as a consequence, to define the disease, you have a genetic variant of mutation, what we now call pathogenic variants in that gene, in the BTK gene, and consequently you have low numbers of B cells and low or absent circulating antibodies. So in the next set of slides, Dr. Hernandez is going to share with you the clinical features of patients with XLA and also share with you some of the novel, non-published data that we have been working on together in collaboration with the USIDNet group.
Thank you so much, Maite. It's truly a pleasure to be with everyone today, and I welcome you also to this session. It's a pleasure always to collaborate with the Immune Deficiency Foundation and to work with my dear friend, Dr. De La Morena, today to present on this topic that's near and dear to our hearts. So I'm going to talk a little bit about the clinical features. And as you all know, everyone presents a little bit different, right? Most of the patients have their own path and their own journey. And as many of you probably can relate to, it's not always an easy path because the diagnosis can be delayed in many patients. Generally, we think about any primary immunodeficiency as starting with recurrent infections. But as we'll talk about later, sometimes it's not that kind of prompts the diagnosis. Recurrent infections can come in many different shapes and forms. Ear infections, sinus infections, lung infections that can eventually progress to lung damage in the form of bronchiectasis, gastrointestinal infections that many people may not think about. In particular, with patients with agammaglobulinemia, we think about Giardia, Campylobacter, and the enteroviruses. And then other comorbidities, what we call comorbid conditions, which can include arthritis, which might be something related to an infection like mycoplasma or ureaplasma, neutropenia, which can affect the colon. We're excited to share with you today some unpublished data that Dr. De La Morena and I have been working on from the USIDNet registry. So we're going to be publishing this soon. These are some of the clinical features, types of infections that are present before and after diagnoses. And as you can see here, sinusitis, otitis media, pneumonia, and then conjunctivitis and skin infections are the most commonly. And these are seen both prior and after diagnosis. As you come over to that's on the left-hand side. If you look at the right-hand side, you can see again that bacteremia or sepsis, which is infection in your blood, meningitis, and then bacterial. Those are the three. So bacteremia, sepsis, and meningitis. There's definitely a difference once you are able to institute proper treatment. And we see post-diagnosis, those certainly decrease, which is important because those are the most serious and life-threatening forms of infection. As you can see, as you move to the right of the slide, the same types of infections that I mentioned, including the sinusitis, otitis media, conjunctivitis, skin infections, pneumonia, and then other things, encephalitis, osteomyelitis, which is in the bones, abscess, other opportunistic infections, and then the bacterial arthritis are seen also. Here we're going to look a little bit at the organ system involvement. And as you can see, the patient cohort was 240 patients total. 51%, the most commonly, it was respiratory involvement that was seen, followed by gastrointestinal. Again, as you can see here, gastrointestinal is something that we see frequently in patients with agammaglobulinemia. Neurologic, which may surprise some patients, the musculoskeletal as well, and followed by hematologic, endocrine, cardiovascular, psychiatric, which is 8%, and then renal, which is 7%. And again, as we go to the right hand of the slide, you can see before is in blue, after is in red. The most common, especially after, is respiratory, again, followed by gastrointestinal, neurologic, and musculoskeletal, and then dermatologic and hematologic as well. So as you can see, patients can present in many different ways, can have different types of organ system involvement, but I think to many surprise, gastrointestinal obviously needs to be considered along with the neurologic and the musculoskeletal. I think in general, people are pretty aware of the respiratory complications, but they may not be as aware of the others. For the diagnosis, so obviously initial screening of immunoglobulins, the total antibody levels, including IgG, IgM, and IgA are important. Looking at the lymphocytes, which is the type of white blood cell, specifically at the B lymphocytes. And I'll say one thing as a clinician over the years, it's important, especially if you have a family history, that in the first 6 months of life, if there is a suspicion or it's the child of a patient that has a family history, I think it's very important to remember that we need to look at lymphocyte numbers, because if you measure IgG in the first 6 months, it could be mom's IgG and it may look totally normal. And we've had families that presented where the IgG was normal, but obviously it was maternal IgG that was passed on while during the pregnancy, and then the lymphocytes were never measured. And the B lymphocytes are very important, so especially in the first 6 months of life. We can also look at genetic studies looking specifically at BTK for patients with autosomal recessive or dominant forms of agammaglobulinemia. Today, we're really focusing on XLA. However, Patients with other forms of agammaglobulinemia can present similar, although there's other genetic causes, obviously, and their presentation may be a little different. So inheritance, Dr. De La Morena alluded to this, but the female daughters of an XLA patient will be carriers as they receive the X chromosome, but the male sons will not be affected because in order for the male, the Y chromosome is passed on from the dad. So female daughters of XLA patients will be carriers, male sons will not be affected, and you can see that here. As far as treatment options, and today Dr. De La Morena and I are going to try to keep this as concise as possible because we want to have time for questions and answers, but the treatment options really are varied depending on what organ systems are involved. So universally, the treatment is gamma globulin replacement. It can be in the form of IVIG or in the form of sub-Q IG, and there's different forms of sub-Q, as well as prophylactic antibiotics for some of the patients. Prompt antibiotics in all patients that have an infection is important. Treatment of the comorbidities, including the colitis, is important. There's different biologics that we can use. Treatment for neutropenia, which may affect some of the patients. Treatment for the chronic lung disease. It's very important to keep a very close eye and have good follow-up for lung function as time goes on. And then obviously the earlier the identification of infections and comorbid conditions, the better. So as far as expectations, most individuals can lead a normal life. And I think that's important. And that's why it's so important to be able to diagnose earlier than later before some very bad or life-threatening infections occur. Children can attend school and extracurricular activities, and they can participate in team sports. There's truly no limitation of activities if the patient's feeling like they can. They must continue gamma globulin therapy for life. I think that this is very important to underscore. And the need to monitor lung function is very important, especially as time goes on. Paying attention to infections also, and discussing a plan of action with your doctor. So one of the things I've said at prior IDF meetings is the importance of having good communication with your medical team and feeling comfortable and feeling you can ask whatever question you may have. And I think that that's something, again, and your medical team consists of a lot of different people. It's physicians, it's nurse practitioners, physician assistants. It might be the medical assistant and anyone else that makes up part of that team that helps take part in the care of the patient. And then practicing mindfulness. I think, during this whole time with the pandemic, I think, I've spent a lot of time talking to people. Number one, we need to take care of ourselves, not only from infection, but in the form of, getting adequate exercise and eating well and treating our bodies well by sleeping well and trying to do things with stress management. And I think that that's all very important. So that helps with your overall health. I'm going to pass it back now to Dr. De La Morena.
Thank you, Vivian. So the next question is, what's next for our patients? And I put up here as health-related quality of life as a very important next step. And again, in collaboration with the Immune Deficiency Foundation and the USIDNet, we have really been able to put together a series of data that we hope to be publishing soon as well, that looks at how patients with XLA are doing. It's not just about the numbers, it's about how your life and how it's impacting your life in general terms. And it's important to understand this because as we move to novel therapies, you need to be a part of that discussion and understanding the quality of life and how it's impacting you. I can share that in general, like Dr. Hernandez said, patients with XLA can lead very normal lives, and it's very important that they take care of themselves. But it's if you start what we've seen, and if you compare to the general population, is the quality of life in terms of domains of physical health and mental health looks very similar, nothing very different. However, when you start looking at things more in detail and you dive into the weeds, you start seeing that those patients that have more than one of the comorbid conditions that Dr. Hernandez talked about, for example, lung, more than one condition or two conditions, it really starts impacting quality of life, both in physical and mental health domains. Also, for example, if you're having to be hospitalized or needing multiple antibiotics through the year, that is impacting. And those are some novel observations that we hope to share with you in forthcoming publication. In terms of gamma globulin preparations, I think one of the things that is very important as a patient is to be mindful that there are many different products on the market and that these products change. And it's important for you to be familiar with what products you're receiving, because what we don't want is for you to have a product changed by your insurance or your pharmacy and you not know about it. Because changes in products from one to another may make you feel different when you're receiving them. So it's important to be mindful and be aware of which ones are the products that you're getting. And if anybody changes a product on you, it's very important that you sort of put a hold and a stop and ask questions. And always work with your provider to discuss any new changes that you may see. And the third is what I'm very excited about, and we are now in the 21st century, is gene therapies. So the history of gene therapy really didn't happen overnight. You know, it's really been over now 60 years in the making. But certainly the last couple of decades have seen really, I would say, very incredible advances. And the reality is that there are ongoing current and completed gene therapy trials for different conditions with primary immune deficiency. And basically, and these include patients with Wispert-Aldrich, patients with chronic granulomatous disease, patients with ADA deficiency, and patients with X-linked SCID, which I'm sure you have heard, and IDF has been very important in telling you about. So what is gene therapy? So basically, I'm not going to go into details, but the body is formed by cells, and within those cells are little packages called chromosomes, and packaged in those chromosomes are genes. And these genes are will instruct the cells to produce proteins or functions in that particular cell. So if we look at the gene for BTK, if we could just take that gene and put it in the cells that it's supposed that are the B cells down here, we would be able to correct it completely. And so this is just a diagram of the cells in that come out of the blood. You can see that you have your platelets here that clot the blood, your red cells that carry your oxygen, and then all the white cells. And all of these come from this multipotent hematopoietic stem cell here. And what happens is that these multipotent hematopoietic stem cells are sort of in a quiet state. They're hanging in the bone marrow. And every once in a while, as is needed, you are producing cells that will give rise to all the cells in the blood. So if you are able to deliver this corrected gene, and in particular this BTK, then what happens is that you want to make sure that it's in that hematopoietic stem cell, because all these other cells may have a life-limiting existence, whereas these multipotent stem cells can last for many, many years in the marrow and are only activated when they're necessary. So what you want to do is add them to these this multipotent or mother cell, if you will, in the marrow. So to do this, you need to have delivery systems, and this is what has been really advanced in the last couple of decades. And so what you can see on the left side is, ideally, it would be nice to sort of say, okay, we're going to take these genes that we have corrected and just put them in the body and have them go to the right pluripotent stem cells and then correct things as we want them to be corrected. And that's what we call in vivo gene therapy. An alternative is what is being done in many of the primary immune deficiencies, is where you take the stem cells, these pluripotent stem cells from the patient, and you isolate these hematopoietic pluripotent stem cells, and then you put them in a test tube, and then you correct them, what we call modification in vitro, here in the cartoon. And then the next thing is, once you are sure that these pluripotent stem cells are corrected, then you infuse them back. And this is the concept that many of the gene therapy trials have been following. And so I'm really excited because we are in a new era, and I think the next years are going to be critical. And the group at Seattle Children's Research Institute, and led by Dr. Rollins, is in that phase where we are, in the next few months, going to be able to have clinical studies looking at the isolation of stem cells from patients with XLA and being able to correct them in the test tube. And then hopefully in the next couple of years, not 10 or 20 years, but maybe in the next couple of years, we'll be able to have this whole process and be able to deliver these corrected stem cells and have the option of gene therapy for patients with XLA. So this is, I think, one of the exciting news. And if anybody in this group is interested, they can contact either Dr. Hernandez or myself, and we would be happy to connect you with the study teams.
Okay, so we're just going to talk very briefly about COVID-19. There is another session by Dr. Kate Sullivan during this meeting, specifically on COVID-19 and the primary immunodeficiencies. And I'd also like to say that Dr. Sullivan has done an amazing job throughout the whole pandemic. There are many different updates that have happened from the beginning of the pandemic, and they've been pretty consistent about primary immunodeficiency and COVID. I've also been able to translate many of them into Spanish. So for the Spanish-speaking patients, I think that that's another resource. But the Immune Deficiency Foundation really did an amazing job, I feel, during the pandemic in giving information, not only to our patients, but really to everybody. So as far as XLA specifically, there are studies that are ongoing to better understand the impact of COVID-19 on patients with XLA and other primary immunodeficiencies. Current reports have demonstrated that patients with XLA and COVID infection have not had worse clinical course than other patients. The COVID vaccine is recommended for patients with primary immunodeficiency, and remembering that none of the currently approved vaccines are live virals, so they are safe, and that really the benefit most certainly outweighs any risk. And because it's not a live virus, you don't have to worry about getting the infection from there. Remembering also that despite the fact that you may not produce the best antibody, or that our patients may not be able to respond with a full antibody response, the vaccine can confer some cellular immunity. So even in patients with antibody deficiency. And then we're looking forward also to the day when there's antibody replacement products that will actually have enough of the antibodies to the SARS-CoV-2, hopefully in the the near future, but that's to be determined. Thank you all for your attention. I think we'll turn it over to McKenna again for the question and answer.
Yep. Thank you, Dr. Hernandez-Trujillo and Dr. De La Morena. We are now going to enter our Q&A part of the session. And I am happy to say we did receive some great questions that I'm going to ask. But for anyone who might have missed the intro, if you do have questions, feel free to message me, McKenna Cresley, and we can have our presenters answer them. So the first question is from an XLA patient. He's been receiving IVIG treatments every 4 weeks. And he would like to know when our IVIG treatments will contain enough COVID-19 antibodies to confidently declare immunity to COVID-19.
So as I just alluded to in the last slide, unfortunately, we don't know. We're hoping it will be soon, but I really don't have I don't know if Dr. De La Morena has an estimated date, but I don't believe that anything has come out. What I am sure of is that the manufacturers will be very forthcoming and let us know when that does occur. But Mike, did you have any additional?
No, I just think that it's important to recognize between the time that the plasma is collected and it gets into your arm, it can take between 18 to 20, to 18 months to a couple of, to 24 months. So it's going to take that time. So we're very hopeful that it will happen in soon, but we don't know exactly when that will be.
Okay. We also have another COVID-19 related question. This XLA patient has received both doses of the Pfizer vaccine a few months ago. His understanding is that there's continued research to understand when potential booster shots are needed for the COVID-19 vaccines from an antibody perspective. Since XLA patients don't create antibodies, but do rely on T-cell response, would XLA patients need booster shots around the same time as the general population, or would their timeline be different?
I'm happy to answer because the answer is we don't know. We don't even know if we are going to need boosters for those who can make antibodies. The very important point that you made is that patients with XLA have normal T-cell responses. And David Hagen recently from Israel published a paper that actually demonstrated that he looked at the responses of the vaccines, not only in terms of antibody production, but also T-cell responses of patients with immunodeficiency. And within his cohort, there were 4 patients with XLA. And even though none of those patients made antibodies, all 4 had very strong, robust T-cell responses. So that's a really exciting and very important part of why, like Dr. Hernandez-Trujillo recommended making sure that everybody gets the vaccine because especially even because the vaccine is not a killed vaccine, it is safe and there may be that specific benefit.
A third question we have is, do monoclonal antibodies, for example, Regeneron, serve any value for XLA patients for prophylactic use?
So that definitely
Vivian, do you want to?
Yeah, I mean, honestly, that hasn't been studied, and I would say for anyone that has an infection, I think, getting to a medical care facility, especially if you have a chronic condition, as early as possible is important, because whatever, and again, this is something that's changing all the time. All of the guidelines are changing, the treatment recommendations are changing. So like what I would urge patients is to definitely seek medical care and speak to your physicians that are aware of your condition. if you have COVID, because I'm not aware of any prophylactic use studies. I don't know of any, or prophylactic use period. But I think because this is really an ever-changing situation, I would highly recommend just seeking early medical care and speaking to the doctors that know you.
Thank you. We have another person asking that they would like to hear more about what neurologic symptoms are seen in XLA patients.
Do you want me to answer that, Maite? So there were a lot of different ones. There were some that included and this isn't, I want to reiterate, it's not the vast majority of the patients, but there were several cases of different things: seizures, epilepsy, like complex pain syndrome. Maite, I'm trying to remember what are some of the other ones. There weren't that many of one particular thing. It was just kind of very well spread out.
And again, I just like Dr. Hernandez said, the point here is that even though you have gamma globulin infusions, don't dismiss if you're having any symptoms that are unusual, and make sure that that is addressed. There are certain viruses that even can occur in the setting of gamma globulin, and that can cause inflammation in the brain and infection in the brain. So we just need to be mindful that if you develop any signs or symptoms to suggest any neurologic changes, that is addressed immediately and not dismissed.
And at what has already been well reported, so like encephalitis due to enterovirus in particular, or meningitis, as Dr. De La Morena said. But yeah, I completely agree that any neurologic change or concern absolutely should be addressed sooner than later.
Another question is it possible to diagnose XLA like SCID at birth via newborn screening?
Yes, actually, one of the comments that Dr. Hernandez made is, I'd like to just point out two things. One is, if there is a family history, and interestingly, most of the time there is not a family history, but I have been surprised over the many years that I've been doing this, that if you delve into it, there is a family history that you can find in up to 40% of patients. So if there is a family history, it's very important for you to be proactive and ask your, make sure that your pediatrician is aware of it, so that you can communicate with your local immunologist, because at the time of birth, the antibodies that the mom has cross the placenta. The IgG antibodies cross the placenta and protect the baby. So the baby's immunoglobulins will be normal, but we can make the diagnosis of XLA right then and there within the first days of life, just by looking to see if you have or don't have the presence of B cells. So that's very important. If there is a family history of BTK, of XLA, and we do know the genetic diagnosis and the genetic variant in the gene, the BTK gene, prenatal diagnosis is also available, and so that might be something that one can consider. The question that the person poses is very important. Can we add XLA to the newborn screening? And there are efforts at trying to identify similar to SCID, where we are looking at TREX, or T cell receptor excision circles, another similar pattern called CREX that will look at the presence or absence of B cells. And so that is in some of the European countries is being looked at as, and in Japan has been looked at to see if one could identify patients with XLA at birth as well. It has not been incorporated in the US just yet, but that is an area that people are certainly looking to identify children with XLA shortly after birth to provide a prompt diagnosis and therapy.
We have another question. Is XLA a diagnosis that might someday be cured by gene therapy?
Yeah, so, you know, I'm always very hesitant on the word cure, but that is the goal and that's what we strive for, right? And so I think that I think we are in a different place than when we were 20 years ago. I was a fellow when the gene was described, which was 30 years after the description of the disease. And now 30 years later, we are now moving to gene therapy. So I'm very excited about this new era. And I think that it will be a novel, you know, I think it provides hope and the possibility of new ways of thinking about things. Maybe it's not gene therapy, maybe 50 years from now, it might be something different. But this is where we are now. And it really, for our other patients with immune deficiency who have undergone gene therapy and have been part of clinical trials, it has been very encouraging, the results, but we're still in the process, and we're still living through this process, right? So it's going to take a little bit of time.
Thank you so much for sharing. And that was our final question. So that means our time has come to an end. So please join me in thanking Dr. Hernandez-Trujillo and Dr. De La Morena for sharing such wonderful information with us today. It has truly been an honor to have you all join us. And I hope you guys enjoy the rest of the conference. Thank you.
Thank you.